Minnesota Organization of Registered Nurses, Park Nicollet Methodist Hospital, Sigma Theta Tau International, the Kappa Phi chapter, at Sigma Theta Tau International Zeta chapter, St. Cloud Hospital, Centra Healthcare, University of Minnesota School of Nursing, and University of Minnesota School of Nursing Foundation. And we absolutely celebrate our collaborators. Mayo Clinic and Mayo Clinic Health System, the Minneapolis Veterans Affairs Healthcare System, and Winona State University Department of Nursing. You will find representatives of each of these organizations with us throughout the day. These organizations also serve as advisors in planning today's program. You'll note in your program that, that each of these designations is in there. I would ask that we celebrate with gratitude all of our sponsors and collaborators for this conference. I also would like to acknowledge the Nursing Research Day Planning Committee, the Community Partner Planning Advisors, and Nursing Research Day volunteers. Will you all please stand so that we can thank you? So to get to the key point of our keynote address this morning, I'd now like to welcome Missy Safner back to the podium to introduce our speaker. Missy.
Thank you, Dean Delaney. Our keynote speaker, Dr. Cindy Anderson, is this year's recipient of the Barbara O'Grady Lectureship. This lectureship honors the legacy of Barbara O'Grady, who was an influential public health leader and generous supporter and alum of the University of Minnesota School of Nursing. It is now my pleasure to introduce Dr. Cindy Anderson, who is a professor and associate dean for academic affairs and educational innovation at the Ohio State University College of Nursing and a women's health nurse practitioner. Dr. Anderson is nationally known for her outstanding leadership and expertise in genetics research related to maternal-child health. Her research focuses on the study of hypertension in pregnancy and the influence that the maternal pregnant environment has on future development of hypertension in offspring. We request that you hold your questions until the end of Dr. Anderson's presentation, as we are recording this presentation. Please join me in welcoming Dr. Anderson.
Well, thank you. I will just start and say it is a pleasure to be here. This feels like my second home. So I spent about 25 years in North Dakota, so it's almost the same, right? And so it's wonderful to be here. I am thrilled to have the opportunity to speak with faculty, students, community, and clinical partners. What a rich group to bring together to advance the work of research and evidence-based practice that has really meaningful outcomes for patients and families and communities. So today I am talking to you about epigenetics and heritable risk for preeclampsia and cardiovascular disease. And as I look at the title, I think, oh, you know, when I started out, did I ever expect that I would be here doing a talk like this? And I will tell you the answer is no. But I hope to be able to spend some time today talking about that journey and have a meaningful message for everybody here to think about how you develop a career, what are the really important pieces and parts that you need to have in place to really help launch you. And I hope that I honor Barbara O'Grady in my delivery of this and her legacy for mothers, infants, and children and public health. So my disclosure, nothing to report. So today I'm going to speak a little bit about my own research journey that led me to where I am and hope that I can really give that message about how every step of the way I had an initial question, I got the answer, which really just led to more questions. And the really critical factor of having mentors and motivators that were with me every step of the way and without whom I would not be here today. And then my light bulb moments, things that I really recognized as I was on my journey that now I try to help share with my mentees as they move towards their own research careers. I certainly will hope that I can speak to you about how the findings of my own research have really linked back to improved patient outcomes, which is really at the heart of nursing science, isn't it? That's what we're all here for. So I'm going to begin at the beginning. My journey started unexpectedly when I was a brand new faculty who just finished a master's degree at the University of North Dakota. And I, like most new faculty, were just trying to figure out how to do my everyday job. And then all of a sudden, we had a new faculty member who is here today. Dr. Sue Henley was a graduate of University of Minnesota, so there's another connection. She was a new faculty at University of North Dakota, and she said to me, "Let's do some research." And I thought, are you kidding me? I don't know what you're talking about. And she said, no, it's okay, it's okay. And so she took me and another colleague, and she provided really lessons that I still use today. It was such an incredible foundation and incredible generosity of spirit to take people and to really not only move me forward, but really teach me how I could mentor people going forward. So she taught me how to write a grant. I got the budget, just saying. That was really fun. She taught me how to use SPSS. She taught me about authorship. Not only how to write a paper, but what it meant to be an author, what your commitment was, how you develop. These are lessons that are so hugely important. And the best part is she made me famous. My first paper, it was so great. It was like, oh, this feels so good. And it was data from the University of Minnesota. So you may recognize some names in this first publication. And it was such a wonderful thrill to be able to do that. And beyond moving my own career forward in terms of giving me a flavor for research, she taught me what it was to be a mentor to students and how to build a team. And I think that's really important. We had a very large honors program, and so she said, well, you help me do this, and then here, you do this. And I thought, oh, I can't do this, but I could. And I didn't see that in myself. We worked with students. This is an example of a manuscript that we developed with one of our honors students. And you can see there's a theme of breastfeeding that goes through. So we had this really strong connection with lactation research. She's the one that made me take the IBCLC exam, which I didn't want to do because it was 5 more letters. But I was very happy that I did it. She really encouraged me every step of the way. And so these are the things that I remember. And my light bulb moment here was that I really recognized that sometimes you just don't see in yourself what your potential is, and somebody else sees it. And my message is, let people help you believe that you can do something that you don't see in yourself. So thank you, Sue. So she also encouraged me to get my PhD and was very patient when I kept saying, I'm not quite ready, but then I made the decision. And I did go on because I thought, there's something else I need to do. And so it was a time where I really had to think about, what is it that I want to do? And I knew, as having been a faculty member, that what I decided I better love, because I'm going to be in it for a while. And so part of my decision, I knew, was to find a really good mentor match, an advisor that could lead me to the next step in my career. And there really wasn't one in lactation, so that forced me to think about, what else might I like to do? And so preeclampsia had always been of clinical interest to me because it is such an interesting problem, and there are so many gaps in what we know about it. And so I was fortunate to have a mentor, Dr. Joseph Benoit, who did vascular work in portal hypertension, which was not related to preeclampsia. He didn't know anything about it, but was willing to take me on. And I knew that he would connect me with the people I needed to. And so I'll tell you a little bit about that. But he was very well connected in the physiology world. And so I was able then to make those connections to other people that would complement the work that I tried to do. So I want to just talk a little bit about preeclampsia to give you a background about what my next steps were. So for those of you who are not familiar with preeclampsia, it is a pregnancy-specific condition, and it's one that is characterized by widespread vascular dysfunction, and this affects every organ system in the body, and we recognize it in the second half of pregnancy through objective signs such as high blood pressure, protein in the urine, and again, this is evidence of the multi-system organ involvement that preeclampsia is associated with. The challenge with preeclampsia is that we don't necessarily know everything we need to about the mechanism, but what we do know is that while we don't see symptoms in the second half of pregnancy until then, the origins of it happen in the first few days after conception with the development of the placenta. So we have this unique period of time where we have pathology developing, and we don't see it until it is so profound that people are symptomatic. That's a problem. And so that led to the really big gaps in knowledge that I was destined to try to address, including the absence of an early screening and diagnostic opportunity. There's nothing to tell us that somebody has preeclampsia until they show us, and at that point it's too late. We also don't have a definitive treatment. Delivery is our best definitive treatment. That's not always the best route to go, but sometimes that's what we need to do to end the pathology, and even with that, it continues for a period of time. We also know it's heritable. For those of us who work in OB, one of the questions we always ask, tell me about your mother, tell me about your sisters. We have known for a very long time that there is an increased risk for preeclampsia if you have a family history of it, but we don't know why. And then we have knowledge that when a woman gets preeclampsia, she has an increased risk for cardiovascular disease later in life. And so when we know that, we don't know why that is. And then I think for those of you who are in practice settings, the clinical implications are that we don't even let women know that. And so we miss this opportunity to intervene and reduce that risk going forward. So those were the things that I really wanted to address. So how did I get here? Well, sometimes the road leads you to places that you don't expect. And so I was in a physiology department in medical school, and they did no clinical work. And so I got introduced to doing my work with an animal model. And so my advisor was wonderful. He connected me with a colleague, Dr. Joey Granger at the University of Mississippi Medical Center, and I got on a plane and I went to Jackson, Mississippi, and I learned to create an animal model of placental insufficiency that mimicked preeclampsia in humans. If you can imagine that rats could mimic humans, but in this case, yes. And so it was a model of reduced uteroplacental perfusion pressure, or what we call the RUP, and it involved a rat getting pregnant and then intervening at the beginning of what would be their third trimester surgically to reduce perfusion to the placenta. Then they would recover, and then they would develop a phenotype of preeclampsia. So a couple of problems here. I was deathly afraid of rodents. So this was a surprise to me. But I also could not tell the people in the lab that because I had to get some street cred. So I don't even want to tell you about that journey. But I got over that, found that they were very, very nice. And then, you know, I mean, learning a surgical technique was not even the issue. It was touching the rat. But anyway, I learned and it was fine. And that became the model that I based my dissertation work on. And so at this point, I will segue into other people that were essential in my career, one of whom is here now. This is Faye Norby, who was an undergraduate student in the lab, who was my partner. She has now gone on to have a master's and an MPH and actually works here as an epidemiologist. So happy to see her progression and on her way to a PhD. But she was my right hand. We were a team throughout this whole dissertation. And it was really just a wonderful partnership working together. And so we created this model. The other good thing about working with rats when you're doing your dissertation, their pregnancy is 21 days. You can actually finish, right? You can get through a lot of pregnancies with rats. These are the practical considerations. So we created this model. We intervened at day 14, which was the end of their second trimester. We did the RUP, or for the rats that were our controls, we did the surgery, but we didn't reduce the perfusion. We didn't add the clips, but they had the same experience. And then we looked at the phenotype of blood pressure, but I was focused on vascular function. And the Granger lab had done a lot of renal work, but not as much on the vascular function. And so we found the changes in blood pressure that we would have expected. So really no difference before they were pregnant, no difference at all up to day 14 when we intervened, and then just in 5 days, those animals that had the reduced perfusion had a significantly elevated blood pressure. So we felt like we had a good phenotype, and that was consistent with what others had found. But then we did the vascular function, and so this is, I'll just tell you quickly, the red is the RUP. I did that so I would always remember. And then here are the controls. And this depicts the vascular response to constrictors. And you can see in the mesenteric artery, which would represent systemic arterial function, it was a much higher resistance, so much more responsive to vasoconstrictors, which would be consistent with what you would expect in preeclampsia. And we also looked at the uterine artery so we could know what was the local effect. And we saw a similar effect there. What was really intriguing is that when we looked at the birth outcomes, we saw evidence of growth restriction. And this is a common outcome in preeclampsia, again, as well due to the placental involvement. So this is where I began to think about what is happening and how can we investigate this further. And so as nurses, we all have a theoretical framework, and mine works around developmental origins of health and disease, which was really gaining popularity at the time, thinking about what happens in the intrauterine environment that sets that offspring up for future risk for health and disease. And so to me, I'm looking at what is the effect on those offspring directly from developing in that environment. But if we think about generationally, or we think about heritability, we have to go out 2 generations. So I began to think about designing my next study, and now I'm done with my dissertation. This was my first foray out on my road to independence, thinking about, let's look at heritable effects of this condition in the offspring. And so we set up a design where we did the same thing. We took those rats, we did RUP on one, we had controls on the other. We mated them. That's really easy. You just put a male and a female in a cage and yada, yada. They're mated. So that was easy. And then we let them have their babies. And so then we were on, as a labor and delivery nurse, this was very appealing to me. So we would be watching on day 20, and we'd watch the babies be born, and they're very, very cute. This is where I started to really like the rats. They're just very cute. But we had a lot of rats. So as you can see, our ends were pretty big. So many in the first generation. And so we had females and males, a little bit less in the RUP group than the controls because of the effect of the procedure. And that was our first generation. But we wanted to take it a step further and say, okay, what was the effect if they mated? Would their children be affected? So that was the F2 generation, so our second generation. The other thing that we really were focused on is differentiating between male and female, because this was about 2004, and even then, people were not distinguishing gender effects. And we had to start doing this. So we were really focused on making sure we did that. And I'm glad we did, because we found some really interesting results. So we, again, looked at blood pressure in these animals. And if you look at the males, the systolic blood pressure, you can see, if you look, the blue is the controls, the red are the first generation of the experimental, and the green are the second generation. And you can clearly see that those offspring that were in that environment had a much higher blood pressure all the way through. You can also see that we had some effects in the second generation all the way through. So they were also impacted by the intrauterine effect, less so than the first generation, but still affected. Their blood pressures were higher. And this began at about week 5. We did weekly blood pressures on all of these rats. Actually, the person who did the blood pressures is now a pediatrician. I feel like I had something to do with that, but I can't take all the credit. And so when we looked at the females, we saw a different pattern. I think it was interesting. If you look to see, especially the red bar, you can see absolutely we had the same effect in that first generation. Blood pressure was high all the way through. But in the second generation, it was pretty stable until week 9, and then it started going up. And week 9 is puberty in a rat. And so this is where they're moving into their childbearing age. So that was a fascinating observation that we made there. The next thing we did was we looked at their vascular function in the mesenteric artery. And I'll show you that in both the male and the female, these are the controls. Again, these are the first generation. This is the second generation. That higher curve indicates a higher vascular reactivity. So the second generation offspring, who were just born to parents that had that intrauterine exposure, had worse vascular outcomes than their parents. And that was very interesting, and that was in both males and females. So in females, they were more comparable, but males worse. So this was a really interesting finding, and this was true where we measured it at 6 weeks, at 9 weeks, and at 12 weeks. So we see this very interesting pattern. So when we presented these data and we started to think about these data, people would say, well, why do you think that is? And it's like, I don't know. Why would that be? And that began my journey to epigenetics, because this was really becoming mainstream at the time. It was used in a lot of studies around cancer, but it was just now moving out to be thinking about that in relation to other kinds of complex diseases that pure genetics could not explain. And so it began my work looking at epigenetics. And so a little bit of background about what is epigenetics, and this will be very brief, but I wanted to use it to really focus on those heritable changes in gene expression, because epigenetics controls the way a gene is turned on and turned off. It is not a change in the bases, so it's not a polymorphism or a SNP of the pure genetic work that people do, but it's a modification, a chemical modification that changes the conformation of the chromatin to allow exposure of those elements that need to be available to transcription factors to turn the gene on. So it's the tightness of the chromatin and the openness or the closedness of that to allow for expression to happen. And this can be modified in a lot of ways. There's histone modification, there's microRNA, and there's DNA methylation. And we knew the most about DNA methylation at the time, but it particularly appealed to me because DNA methylation not only has a role in disease, but it has a very large role in development. And so if these issues are happening early on in children because of placental development, that influence, I think, is really an important one, and also looking at what is the particular role of DNA methylation in development and how could that be altered as a potential explanation. So just to illustrate this, because I think, when you hear these terms, epigenetics, some people say, oh, can't hear you anymore. I've got a simple animation that kind of maybe will help explain that. And so this is just an example of a gene in the promoter area, also known as a CPG island, because it's very rich in cytosines, the cytosine base. There's a promoter area, and that is involved in turning the gene on when it's activated. But not only do we have the CPG islands that have always been the target, but we have flanking areas, North Shore, South Shore, North Shelf, South Shelf. So these flanking areas are also influential in their methylation status in terms of gene expression. So typically what happens is a transcription factor comes down, it binds to that promoter region, and it turns a gene off, and that gene is expressed. And then we have our triplets, and we have our message, and then we have transcription, and we go forward. When we have methylation of the cytosines in the promoter area or even in the flanking areas, when that transcription factor comes down to bind, that binding is attenuated. And so therefore, if it doesn't bind, there's no turning on of the gene, and the gene expression is repressed. So you don't get the protein product. And so the methylation is really determining what is happening. And that could be true not only in the promoter, but also in the shores and the shelves. And so that's really kind of the chemical modification. It's just adding a methyl group onto these cytosines, and the degree to which they're methylated influences how a gene is transcribed. So that was the epigenetics lesson. But what does that mean? I wanted to look at it in development because this figure just depicts the rapid process of methylation that is physiologic at the time of conception, and how potentially that can impact future generations, because it also is involved in primordial germ cells, gametogenesis, and the picture here really is what is going to take this home. We have a woman who was pregnant with her daughter. While she was pregnant with her daughter was developing all the oocytes she would have for her life. So even though the daughter is what we think about, those grandchildren were in development at the time that mother was pregnant with her daughter. And this is that transgenerational inheritance that is so important. And therefore, in those early periods of time and throughout development, alterations in genetics in the mother can actually influence those grandchildren. So I always tell my kids, don't blame me. That's my light bulb there. So as we think about this in health and disease, it's really complex because it not only involves the individual, but the family, and it involves not only exogenous exposures, but endogenous exposures. So things like stress and environment, things like medications, things like anxiety, depression, they all have the potential to alter DNA methylation and therefore change gene expression. So here I am, a nurse with a basic science background in physiology, and I want to study epigenetics. This was not a natural next step for me. And so I needed support here, and I really did. I had a dean at the time who said, you know what, if you want to do this, go get trained. And I got a $5,000 stipend, and she said, go find somebody. So I just started emailing people, and they answered me. And I had somebody, ironically, from Ohio State who said, come and see me. And I got on a plane and went to Columbus and spent 2 weeks in a lab and learned with my own samples, so I could get pilot data, how to do a method that would give me the information that I needed. So I had all these vessels from these rats across a generation so I could look at the differences in DNA methylation in these rats. And that was wonderful. And then I came back to my faculty position, and I was associated with the lab, and the scientist I was working with had that equipment and had been to the same lab. And so I came back and had a place where I could continue to develop that work. And so we worked on it a little bit, but I have to tell you that this was a very cumbersome process, and it was antiquated probably in a year and a half. Just completely not used ever at all. And so I was fortunate that we could move on. We went to the next method. But there was a lot of banging my head against the wall, doors that would not open until I got my next mentor and colleague. This is Dr. Joyce Ohm, who arrived at UND from a postdoc, a 4-year postdoc in epigenetics at Hopkins. And so she, for me, was the link that I needed because my knowledge was coming from working hard and reading and trial and error, and she came, and that was the day everything changed for me because we came together. She doesn't work in my area. She does stem cells and studies sarcoma, but it didn't matter because she enjoyed collaborating with somebody who was doing clinical work, and we came together, and that's where it changed because we were able to then develop a partnership where I didn't have to feel bad that I wasn't the expert in epigenetics anymore because I had a partner and I knew to ask the questions, and she helped me develop in my knowledge and expertise to the point where I can help to mentor others, and then when I get stuck, I just take them to her lab. So it really is a wonderful partnership, and I'm very, very grateful for her. But that's where my clinical work really started to take off because she was a great colleague in helping me move that work forward. And so the first study that I did was looking at early pregnancy epigenomic biomarkers in preeclampsia. This was where I wanted to begin because I thought if there is something happening in the placenta early in pregnancy, can we detect that by looking at DNA methylation changes? And that would serve as an early biomarker. So I wanted to study that in women as a biomarker that we could be able to use clinically. But also mechanistically, I wanted to begin to think about that heritability factor. So I looked at the placenta as a proxy for the fetus in terms of thinking about what changes there might be in DNA methylation with preeclampsia. And so that really did target my goals for trying to understand mechanism, to address a process for early screening and diagnosis, and to be able to look at underlying mechanisms that contributed to heritable risk for preeclampsia. And so to do this, we set up a longitudinal prospective design. This is a challenge in this kind of work because the risk for preeclampsia, the rate of preeclampsia is about 5 to 8%. So you have to recruit a lot of women to get the number of women that you need. And then you need money to be able to do the work. So we started this pilot looking at nulliparous women, women who had not delivered a baby because they are at highest risk for preeclampsia. We drew blood in the first trimester of pregnancy before they would have any symptoms. And then we looked at DNA methylation in the white blood cells we extracted from that blood draw. We also looked at the placenta at birth and then medical record abstraction for diagnosis. Here's a challenge with epigenetics. When you do traditional genetics, it doesn't matter what tissue you have. Your genome is your genome. With epigenetics, it's tissue specific. And so when you're doing a study about preeclampsia, what is the tissue that you are interested in? So I think that's one question. But as a nurse scientist, what is the tissue I can access? That's the other question too. So it was really, we had no idea if this was going to work or not, but we could access blood. We could get white blood cells. And so that's what we began with. So we we extracted the DNA from those cells, and we used the Illumina beta ray. We used the core here at University of Minnesota, and at that time, the state of the art was that you could measure methylation in over 450,000 individual cytosines, so very quantitative, which is very appealing. And then what we did is we looked at the differences between the methylation in the women who developed preeclampsia after we could classify them, and then in those who did not. And so we ended up having an N of 6 of women with preeclampsia, and we matched them with controls for some of the DNA methylation studies. I will tell you, this is just the measurement of blood pressure, systolic and diastolic, among the women with and without preeclampsia. And I think the take home from this slide is that these women did not develop hypertension and get the diagnosis of preeclampsia until very late. So it was at the time of labor or in the early postpartum. And so they were very consistent in that. And really in the preeclampsia literature, there's a lot of data to support that perhaps those that develop it late and those that develop it early were dealing with two different syndromes. And so these are women who typically had a later onset and likely a more mild phenotype than those who would develop it very early on. So I thought, well, that was an interesting observation. So we took those 6, we matched them with controls, and then we looked at the DNA methylation. And so this is a heat map that depicts the differences in methylation compared to the unmethylated versus the methylated probes, and that's what depicts the difference. So here the green is depicting a ratio of unmethylated predominantly, and then the red, it's higher methylation. And so here what you see are these are the 6, each row represents the 6 matched normotensive controls, and here these 6 rows match the preeclampsia participants. And I can tell you that this was a very good day for me, because even if I didn't know anything, I could look at this picture and say, this looks different. And it was so exciting. And I think that's the beauty about doing research. It's like you ask this question and you wait for the data and you get an answer, and it's exciting either way, but when it's where you're thinking, if it's in line with your hypothesis, it makes you feel really good. So this was so exciting because nowhere had anyone ever seen these changes in the first trimester. So this represented the beginning point to say, maybe there is a difference, and maybe that difference can be used as a screening tool early on so that we can actually identify those who are more likely to develop preeclampsia. And so because I was very interested in clinical application, we took it to the next step and we said, let's look at some analysis that would help us identify a biomarker. And so we did what is called nimble analysis. And really all that is it took the participants and it looked at the greatest distance between the preeclampsia group and the normotensive controls. And what this is showing is the results of that, and we identified 20 spots, 13 of which were associated with known genes. We still have spots that we don't know what they're associated with. And so that was the beginning of our work to think about, could we actually develop this? And this evolved into a patent. We're still looking for a company that can help us take it and develop it for use, because right now it's just not practical to use with this method. But this would be a way in which we could advance that work and be able to identify women early on. So that was an exciting finding for us. And then we were interested to know, were there similar changes in the placental tissue that we found in the mother's blood, if we're thinking about heritability? And so we looked at the DNA methylation changes in the placenta, and we found that of those methylation changes that had a loss of methylation, when we looked, we saw some common findings in the placenta, where we had a decrease in several of the same areas, and we did the same thing with the increase. Most of the changes had increased methylation, and we saw very common patterns in the placenta, which made us think, okay, we may have some indication that there is some heritability and we have placental origin. And so we were able then to move on to the next study, and this was actually not the primary outcome, but in the study, we were following women at 28 weeks at birth and at 4 to 6 weeks postpartum, and their babies at the same 4 to 6 weeks of age, infancy. And we had a different primary outcome, but as it happened, 2 of the women in the study developed preeclampsia. And so we took that opportunity to look to see, do we see a difference longitudinally, and is that transferred to the infant? And so we, again, had blood samples on all of these women and the infants. And so this would be the women at 28 weeks, and this is what they looked like at birth. And so here is the 2 women with preeclampsia, and these were all the controls. And again, I think you can see that there are some significant differences here between those women who were destined to develop preeclampsia, who hadn't exhibited symptoms yet, at 28 weeks and at birth. Sorry. And they persisted in the postpartum period at 4 to 6 weeks. And then we did a heel stick on the babies at the same time, and we looked at the DNA methylation changes for them. And so this is the infant, and I think I'm really struck with, as I was comparing the two, these infants look very much like their mothers at the same time point. And you can see, again, this baby looks a little bit more like the controls, but different elsewhere. So we have some differences, very difficult with two babies to be able to pinpoint how important they are. But it does provide some evidence that even with the babies, they have a different DNA methylation pattern when they're born to mothers who have pregnancies complicated by preeclampsia. So that is something that adds to our evidence longitudinally about those linkages. And so from there, we decided we also wanted to do a pilot to investigate the other concern that we had regarding the future risk for cardiovascular disease, and what was that link between preeclampsia and future heart disease. And so we just did a very small pilot to look at that persistence and to see if those biomarkers we identified in the mother were also linked to women remote from preeclampsia, so women that had gone on and developed hypertension. And so we decided we would do that in blood. We brought the women in. We did a lot of other work with them, but I'll just report the DNA methylation. And then we also wanted to look at the feasibility of using saliva, because when we're doing these kinds of studies, especially longitudinally, it's wonderful to be able to follow women using something that's less invasive, and also to be able to examine the infants and the children using a less invasive approach. And so we just did a couple of pilots using saliva to see if we could get consistent results, again, because of the tissue specificity issue. And then we also looked at functional pathways in which that might be affected by the changes in DNA methylation. So again, this was designed to identify the linkage between preeclampsia and future risk for cardiovascular disease. And so again, this was a pilot, and we recruited women who were between 30 and 55 or 60 years of age, who had a history or who had a prior pregnancy and who currently had hypertension. Of those women, we had 3 that had history of preeclampsia and 9 that did not. So we stopped the pilot when I transitioned from University of North Dakota. And so we have just a small group here. But I think this slide, what I want to point out is that the mean time from diagnosis with preeclampsia to when we did the study was 23 years. So these women were older. It was a long time ago where they had that diagnosis of preeclampsia. And so when we looked at their DNA methylation patterns, these are the 3 women that had the history of preeclampsia years before. These are the women who did not, but they all were hypertensive. And even though they were all hypertensive, there was a significant difference in the pattern of DNA methylation in the women who had had a history of preeclampsia compared to those who did not. And so, again, that provides some early pilot evidence, proof of concept to say, let's look at this a little bit further and see if we can look mechanistically at what this is. And from my perspective, does this inform treatment responses? Can we use this information in terms of even thinking about women who are destined to develop cardiovascular disease versus those who don't? Not every woman who has preeclampsia gets it, but the risk is much higher. So I think there's a lot of clinical applications in terms of how we would take this and transition this into something that we can use certainly for clinical decision making. The other thing I thought that was interesting is we looked at the DNA methylation as it related to the saliva samples that we had, and we saw the same changes with saliva. So this is really an important clinical utility in terms of being able to access more women and be able to access samples. So that was an important proof of concept as well. When we looked at those same biomarkers and thought, okay, do they look the same? Are there differences? And of course, you would expect in 23 years or maybe 30 years, some other factors might alter your DNA methylation status. So we wouldn't expect all of them to be the same, but we did have some consistencies. There were 4 genes that were still associated with the hypertension in women with preeclampsia that were consistent with what we found in that first trimester. So my question then is, were they there before they got pregnant? And my guess would be, if it's heritable and if these are the links, then perhaps yes. And so the challenge is a lot to do a prospective study in the first trimester, and then to think about women of childbearing age who are thinking of getting pregnant is really kind of daunting, but I think that's really where the work has to be. We need to know what is women's status before pregnancy and then move on. And it may be that we can tell that when they're 1 or 2 or 3 or 13. So in terms of what we found, DNA methylation patterns are really, truly significantly different in pregnant women prior to the onset of preeclampsia, in placental tissue of fetal origin, in infants born to pregnant women who have experienced preeclampsia, and also in women with hypertension and a history of preeclampsia into the future. I think the other important factor that we had was that we have the potential to use saliva rather than blood, and really have to try to think about how do we explain the tissue specificity issues, and that perhaps the pathways might be a little bit different, but if we're looking at it as a way to identify a marker for risk, I think that's an important factor. And it may be that we need to take advantage of other tissues, other sources to do that mechanistic work. But again, it's very difficult to do that depending on what outcome you're studying. I think the functional pathways, I didn't talk a lot about that, but when I looked at the functional pathways, you can go in and look at lots of different packages to be able to identify, are there linkages between these genes that would explain a certain particular pathway, and does that pathway have biologic feasibility to the topic that you're studying? And so over and over and over again, and it's probably not a surprise, immunologic function came up. And it makes sense in terms of looking at white blood cells as our source, but it also makes sense in relation to preeclampsia, because if you think about the immune tolerance that has to occur for pregnancy to begin with, and perhaps the loss of immune tolerance that could influence the way the placenta implants or vice versa, it makes a lot of sense. Also, certainly vascular pathways came up, which is not a surprise, and neurologic pathways were very consistent across all of the analysis that we did, which would potentially make sense if we think about the progression of preeclampsia to eclampsia associated with seizure activity, or even the risk for future hypertension associated with stroke. So I think they're really important areas that need a lot more investigation. So I can't end this without giving a plug for preeclampsia. I know it's the end of April, spring's right around the corner, but May is Preeclampsia Awareness Month. It's really important for women to be educated about preeclampsia. Many still don't know what that is. And so to have a conversation about that, to understand what those signs and symptoms might be, and I would make a plea for those of you who deal with women and know that they have a history of preeclampsia to use that opportunity to talk to them about their risk. It's such a wonderful window to be able to identify what that risk might be and what you can do about it. And I think about this often in relation to diabetes. We have women who develop gestational diabetes in pregnancy, and it's very well accepted that they have an increased risk for type 2 diabetes later in life. So we take that opportunity. They have lived through knowing that they had diabetes. They have maybe had to use insulin or alter their diet, and they've had that lived experience. And while it may go away when they're no longer pregnant, they can use that experience to say, okay, let's avoid this in the future. Let's put this off. Let's do what we can to reduce that risk. and we don't use that opportunity in preeclampsia. You know, this can be a very difficult challenge for women when they experience this. They have a healthy pregnancy, and all of a sudden something happens. And maybe we intervene at 24 weeks and have to deliver that baby, or maybe they have some very significant multi-system organ involvement. And it's very traumatic. And so there's a way then to capitalize on saying, you know what, that was a pregnancy-associated issue. You have recovered. Now let's talk about what are the ways that we can prevent this. We have evidence-based cardiovascular prevention opportunities. We know we can screen, we can do all of these things, but we need to acknowledge that, and we need to incorporate that into everyday clinical practice. And then the last thing I will say is this is my motivation for the women in this world who are at risk, and particularly for my 3 women who are getting close to that time, God willing. I hope they don't watch this. So, you know, I think, again, to serve as an advocate for women, for public health, for children, to be able to learn more about preeclampsia, to screen it, to treat it, to prevent it, and its pregnancy complications and future sequelae is a major goal of my career, and I hope you can help spread the word. And with that, I think I will stop and open it to questions.